Good evening, everyone. Am I audible?
Yes, ma'am, you're audible.
Okay. And what about the previous classes? Is everything clear about that? We started from the anatomy of uterus. Can anyone tell me the margins of uterus? Length, breadth, and width. That's simple. 3 to 1 in inches. Okay. The segments in which uterus is divided. Parts of fallopian tubes. How many parts of fallopian tubes are there? It's a humble request or suggestion, whatever you can say. Please go through the previous slides also, okay? When we know about the anatomy of the uterus, then and the physiology and the functioning, the menstrual cycle, then we will know about the when we know are aware about the normal everything, then we will better know about the abnormalities. And when we know both normal and abnormal, then only we can know that how to treat that. Okay. So for the treatment purpose, as we all are here to give better treatment to the society. So when you know, first you have to know what is the normal everything. And after that, you have to know abnormalities of that. And then you will find out the ways to treat. Many protocols are being made, and during practice, many things you can do by your own. You experience that here it is the difference between the normal and abnormal. Now I can do that also, that may change. That's beyond the protocols. You can add or delete many things, but how can you do that? वही नॉर्मल प्रोटोकॉल चला या दूसरों से जो भी है, उन्होंने भी कहीं ना कहीं नॉर्मलिटी एंड एबनॉर्मलिटी के बीच में डिफरेंसेस एंड व्हाट इज द रीजन बिहाइंड दैट एंड हाउ टू बैलेंस दैट, इतना एनालाइज किया होगा तभी ना हुआ होगा. So please go through all the classes, not about mine only, others classes also. When you are giving time, dedicating your part of your life to that any course, then you must take advantage of that. And everything is available. PPTs are available, recorded videos are available. So just take benefit of that. This time will never come again. Okay. So just take out some time from your busy schedule to go through that. Till now, we discussed about the normal pregnancy and procedures. That what is the normal anatomy, and including that some about the physiology, about the process of fertilization, and when fertilization continues, that how will be the pregnancy and the change during the pregnancy, and all that things we discussed about the normal things. And after that, the process of delivery, stages of labor, and including that we add to improve that normal procedure. We discussed about the yoga in the pregnancy, the diet of the normal government protocol which is being followed, and what we can add from the ancient terms. So all these things were discussed about the normal process, and in between those we discussed little abnormalities also. But from today we will discuss about the some abnormalities, like if the fertilization takes place in the ampulla, and after that implantation is done in a week's time. We all discussed about those in previous classes. And the pregnancy is, or the fetus is settled in a amniotic sac in the uterus. This is about the normal process. But sometimes the pregnancy continues the parts other than the uterus. So what is that? Many of you are aware of that. When pregnancy continues beyond the uterus. If it continues in in the uterus, then it's the normal pregnancy. But if pregnancy continues in the parts other than the uterus, then what we will call that? Any term for that?
Ectopic pregnancy.
Ectopic pregnancy.
Yes. So, ectopic pregnancy, when the pregnancy continues other than the uterus, and most common area of that is fallopian tube. But other areas are also involved. But as the fallopian tube is connected, and many of the reasons are there for that. So the common area is the fallopian tube for the that 90% of the ectopic pregnancies are in the fallopian tubes, and other than that in the abdominal sac, and many areas are also there. So today we'll discuss about the ectopic pregnancy. Ectopic pregnancy. As we see in the figure, the parts of the fallopian tubes are shown: an ovary, peritoneal cavity, cervix. So the implantation or the fetus is shown in the areas other than the uterus. And when pregnancy continues in the areas other than the uterus, then it comes under the ectopic pregnancy. See, here uterus is blank. If in the interstitial part of the tube or tubal isthmus or ampullary part or infundibular part, or in the ovary or in the peritoneum and the cervix, then it is ectopic pregnancy. So what is the ectopic pregnancy? Ectopic pregnancy is also known as ectasis or tubal pregnancy. Is a complication of pregnancy in which the embryo attaches outside the uterus. An ectopic pregnancy occurs when the fertilized egg attaches itself on the place other than inside the uterus. The normal place of the fertilized egg to grow is inside the uterus, but area other than the uterus, when it grows, then it comes under the ectopic pregnancy. And tubal pregnancy is a name given because it is the most common site. But as we seen in the figure only, that cervix and ovary are also the places, or peritoneal cavity is also the place. So it might not be the tubal, but due to its prevalence, parallel term tubal pregnancy or excisis is given. So ectopic pregnancy occurs when fertilized egg attaches itself in a place other than inside the uterus. So what are the probabilities? There are 4% in among the ectopic pregnancy. 4%, if we talk about the ovarian, the rate or ratio is 4%. About the femoral end of the fallopian tube, then 5% chances of ectopic pregnancy is there. And the most common ampullary part is 78%. And in isthmus, 12% probability is there. And in the coronal end, 2% possibilities. And abdominal pregnancy, it's the rare that less than 1%. Uh, as you see, the normal process of fertilization, that ovaries hatches the ovum that comes to the from the femoral and to ampullary, and fertilization takes place, and after that implantation takes place. So these are the areas for the passage of the ovum, and there might possible quite possible that sperms go there and attaches earlier or later, and didn't praise itself or implant in the uterus. But after the fertilization, and that fertilized part will go to the abdomen, is very of the rarest form. So the chances of the abdominal pregnancy is less than 1%. And in the cesarean scar, after the cesarean section of the delivery, the layers of the uterus or the muscles and the abdominal layers all heal by itself. A simple suture is given, but the healing is self-healing process. That's why it's said to avoid the heavy weight and all that for at least for the 6 months, because this 6 months of time is for the repairing of the tissues and muscle and every layers of the uterus. So when cesarean section is done and by chance the female is conceived early, so it is quite possible that in between that those scars the pregnancy continues or the fetus continue to grow. So these are the pregnancy in the cesarean scar is 1%, and in the cervix that you, it crosses down the uterus, the fertilized egg crosses the uterus and comes towards the cervical part and continue to grow there. So there are very minimum chances that 1% of in 1% of cases it's there. And many of the time the cervical pregnancy shed down with the menstrual blood and nobody knows even. So it's quite possible, and it grows in 1% of the cases and then it comes under the ectopic pregnancy. So what is the etiology? Inflammation and scarring of the fallopian tubes from the previous medical conditions or infection or surgery give platform for the ectopic pregnancy. Uh, when the fallopian tube is normal, its motility, cilia, all that works in the normal way, and it propagate or facilitate the fertilized ovum to grow in the uterus. But due to these conditions, like inflammation, scarring of the fallopian tubes, the cilia doesn't work properly or the motility is decreased. And many conditions are there for that, like infection, like tuberculosis is the most common, and post-surgical inflammation and scarring sometimes. So as you see in the figure, the inflamed fallopian tube is there and normal fallopian tube is on the other side. So when it is inflamed, then you understand that how it is difficult to propel the egg further, and it continues to go inside the fallopian tube only. And in the other figure, fallopian tube is blocked by the scar tissues. Here it is blocked, so it is not possible to propel the egg further, and sperm here in the ovary or the infundibulum pump, and it is quite possible that with the flow sperm comes here, fertilization occurs, and it continues to grow here in the tube only. So these are the reasons, and the hormonal factors are also there. Some genetic abnormalities or congenital abnormalities also support the tubal pregnancy or the ectopic pregnancy. Medical conditions that affect the shape and condition of the fallopian tubes and the reproductive organs, as we discussed earlier also. So there are many conditions that affects about that, and many anatomical defects are also there. So what are the risk factors? These are the about the conditions, and these factors facilitate those conditions, like maternal age of 35 years or above, that is comes under the elderly primigravity. So it is advised to have pregnancy, at least first pregnancy, before 30 years of age, and after that it comes in the elderly primigravity, and after the 35 years of age the chances of abnormalities increases. History of pelvic surgery, abdominal surgery, or multiple abortions. So these also facilitate about the surgery. As we discussed, the pregnancy may continue in the layers, or due to surgery, some scarring is there, and due to multiple abortions, the motility and the normal anatomy physiology of the uterus might be disturbed, so it facilitates the ectopic pregnancy. History of pelvic inflammatory disease due to inflammation also, as we seen in the figure here, that it is inflamed fallopian tube. So due to inflammation also, it is difficult to continue or to propel the eggs towards the uterus, and quite possibility of the tubal pregnancy. History of endometriosis. Endometriosis is the endometrium layer of the uterus is inflamed, so it may not support the pregnancy, and possibility to the fertilized egg to grow in other parts other than the inside the uterus. Conception occurred despite tubal ligation or intrauterine device. If any intrauterine device is there, as the mean of contraceptive device. And in rare of the rarest cases, it is possible that sperm may go up to the fallopian tube. But due to that device, that fertilized egg is not able to come towards the uterus. So fertilization occurs there and it continues to grow there. So this is very one of the common cause of the ectopic pregnancy, IUDs or tubal ligation. Conception aided by the fertility drugs or procedures. In the case of infertility, in the aided fertilization of fertility supports are there. So it is quite possible that it may continue to tubal pregnancy or ectopic pregnancy. Smoking habits and history of ectopic pregnancy. If some female had gone through the first pregnancy as ectopic, it is quite possible that second may be the ectopic. That's due to the general anatomy physiology of that person. And a history of sexually transmitted diseases such as gonorrhea and chlamydia, that is quite possible to have ectopic pregnancy. Having structural abnormalities in the fallopian tubes that make it hard for the egg to travel. So the reason for the above is also the same, and here due to the structural abnormalities. There were some reasons in the previous cases, and here the structure is different or abnormal, so it may not support the egg to travel further. Now, what are the signs and symptoms of the ectopic pregnancy? So here we discussed about the risk factors and the reasons or the etiology of the ectopic pregnancy, and the most common or the gist of the discussion was that the inflammation, if the tubes are inflamed or any scarring is there. So possibilities of ectopic pregnancy increases, and there are some of the reasons. In the case of genetic disease or elderly gravida or elderly female 35 or above, and the pelvic inflammatory disease or the previous history of ectopic pregnancy, it is quite common. And some sexually transmitted diseases and diseases like tuberculosis also promotes the ectopic pregnancy, and structural abnormality can
Ma'am?
also reason. Yes.
Ma'am, how could be the reason of history of endometriosis can be the cause for ectopic pregnancy, ma'am?
As due to the endometriosis, it the inside of the uterus is sometimes not able to support the pregnancy. So that you can say the normal process is like in a computer, it might be confused. You can say in the layman language that fertilized egg might be confused that it is not my proper place to go. That first the fertilized ovum, as we discussed in the normal adhere to the wall of the endometrium there. So it's quite possible that egg can't adhere to that area. So it may propel further towards the cervix or any other place where it find the quite possible to adhere. There it continues to grow other than the inside of uterus.
Okay, ma'am.
Okay.
Yes, ma'am.
But what are the signs and symptoms? Nausea and the breast soreness are the common symptoms of both ectopic and normal uterine pregnancy. It is the common sign of pregnancy. And during the ultrasonic imagings and other technologies, we can find out that it is ectopic. Sometimes the following symptoms emerge: sharp wave of pain in the abdomen, pelvis, shoulder, or neck. So, if a female with the pregnancy and pelvic area, for the other abnormalities also. And one of the possibility of ectopic pregnancy can also be there. And a severe pain that occurs on one side of the abdomen, that indicates more about the ectopic pregnancy. That area of the abdomen might be the area for the ectopic pregnancy. So severe pain that occurs on one side of the abdomen, light to heavy vaginal spotting or bleeding. Our body or the nature made our body in the way that if there is any abnormality, it gives the signals that something is abnormal. So pain, that is signal. Along with pain, spotting is there. So whenever spotting is there, the concerning doctors just try to stop that bleeding and try to continue that pregnancy. But just many times it is very necessary also. But just take the other side of that also, because if anything is abnormal, nature tries to destroy that. So these are the reason why it is spotting is there or bleeding is there. So find out the cause of the spotting or bleeding instead of just stopping that. Yes, you try. If it is normal, then you have to stop that. But along with stopping that, just try to find out the reason for that. So dizziness and fainting is also one of the symptoms, and the rectal pressure increases. The pressure per rectum, feel heaviness and some pressure like. And how to assess or diagnose? Uh, Patient's history should be taken properly. Physical examination. In pelvic examination, you have to check for the pain, tenderness, or any mass felt. In the case of cervical pregnancy, it can be felt about the human chorionic gonadotropin levels. The level of HCG is double in early in the normal pregnancy every 3 days, but are reduced or in abnormal or ectopic pregnancy. Suppose you have done the HCG today and after 3 days. So after 3 days, the level of HCG is double. That means it is normal pregnancy. But if it is not doubled or it is same or reduced, that means there is some abnormalities or it might be the ectopic pregnancy. As we discussed just in the previous point also, that human chorionic gonadotropin hormone is to support the pregnancy, but the nature is the best healer or the best doctor. So when nature see that this pregnancy is abnormal, it is better to discontinue that. The levels of HCG, instead of increasing, it remains the same or start reducing, that it is better to abort that. So by the HCG readings, we also know or guess about the ectopic pregnancy or any abnormalities. And if everything is normal, you can see the HCG injections are also being given. So if you see everything is normal, then it is better to support. But before giving any treatment, please take out the reason for that. In the reports, if any abnormalities are there, just don't give the blind treatment as per the protocol, that if it is low, I have to give the progesterone or HCG or whatever. Just go for the reason first, that you are trying your best to continue the pregnancy. But if it is tubal pregnancy or it may rupture, then it may take the life of the that woman also. So please go for the reason even. And sometimes this is life threatening also, or it may make the women infertile for throughout life. So if you diagnose the ectopic pregnancy and treat it as soon as possible, then it may save the life or the fertility of the female. Now about the serum progesterone levels less than 5 nanogram per ml are considered abnormal. Levels greater than 25 nanogram per ml are associated with the normally developed pregnancy. So here again, progesterone supports the pregnancy and the levels are diminished in the ectopic pregnancy, because pregnancy is not there in the uterus. Then body is not producing the progesterone. And transvaginal ultrasonography, we can see the structures, bladder, uterus, ovary, and ectopic pregnancy is there, not in the uterus but in the fallopian tube, as you see here with the blue color. This is the uterus, and fallopian tube come from the uterus, and this is the ovary. and in the anterior of the uterus is the urinary bladder. So the shaded blue is the area which is enlarged. The normal tube is enlarged here due to the ectopic pregnancy. It is image is taken by the vaginal transducer. And you can see here one thing more, that IUD is also placed here in the uterus. So this fertilized egg can't be hatched in the walls of the uterus. So it is placed here and continues to grow, and it converted into the ectopic pregnancy. In the ultrasonography also you can see the gassed sac, the tubal region. In the laparoscopy, laparoscope is inserted per abdomen, and gas filled area of the abdomen, uterus, bladder, and that loop in the fallopian tube is for the ectopic pregnancy. That loop in the fallopian tube shows the ectopic pregnancy. So these are the methods of the diagnosis. I can see here that the normal tube and the area of the ectopic pregnancy, how it is growing. The fetus is growing here. So there is limits of the fallopian tube. It can't support pregnancy like the uterus. So in many of the cases, if it is not diagnosed, then it may rupture the tube with the severe infections also. What are the methods of the management? So here we know what is the ectopic pregnancy, what are the possible reasons for the ectopic pregnancy, and how to diagnose the ectopic pregnancy. And now we'll come towards the management. Methotrexate. It is a type of the medicine that interferes with the DNA synthesis and stops the cell from dividing or multiplying. It can be used as a way other than the surgery to treat an early, small, unruptured ectopic pregnancy. So as methotrexate stops the division of the DNA cells. So if we diagnose the ectopic pregnancy early, then we give it and it stops the growing fetus and also stop further complications. And what is the treatment regime? Day 1, we have to give methotrexate 50 mg IM. In day 4, measure quantitative HCG level. It is common to see a rise in serum HCG levels from the day 1. At day 7, measure quantitative HCG levels. If there has been decline of more than or equal to 15% from the day 4, then follow the treatment, and serum HCG levels weekly until less than 5 ml international unit per ml. So the indicator to give the medicine is the serum HCG level. Up to the 5 international unit per ml decrease in the levels of the HCG. When we see that, till then we have to give the methotrexate to stop the division of the cells. And this is for the early ectopic pregnancies. And other treatment, if there has not been a decline, if it is decreasing the levels of HCG, that means pregnancy is not continuing further, levels are decreasing. And if there is no decline in the levels of HCG, or it is more than equals to 15% from the day 4, then second dose of methotrexate 50 mg per m into intramuscular should be given to the patient, and it is taken as the new day 1 treatment protocol. And again, HCG level should be measured again on the day 4 and day 7 after the second dose. If values raised or is declined by up to the 15%, then follow serum levels weekly until it comes less than 5 international units per ml. So the concern is that first on the day 1 we have to give methotrexate. We have to repeat the HCG level. If it is below 5 international unit per ml, then we may stop. If it is not, and it is more than 50%, then we have to give second dose, and again we have to repeat the test. And if it is not declining, then the surgical interventions should be done. Many surgeons suggest removing the embryo and repairing any internal damage. This procedure is called laparotomy. So you can say it is the safest and the earliest intervention also, just to remove that. So many of the surgeons we that are expert in the laparoscopic procedures that suggest that removing of the embryo and the repairing, if there is any internal damage, then repairing that as soon as the possible is the best choice of treatment. Because if it discontinues, then it okay. But if doesn't stop growing, and the if the fallopian tube ruptures, then that condition is sometimes very critical. So you have to take the decision wisely that how to treat that. Now about the complication, most common complication is the rupture with internal bleeding, which may lead to hypovolemic shock. And death from the rupture is still the leading cause of death in the first trimester of the pregnancy. So, as we discussed in the session earlier also, that the complication, that is the rupture, is the critical, and that may lead to the severe bleeding and results in the hypovolemic shock, and that results in the death. And it is one of the common cause of the death in the first trimester of the pregnancy due to the tubal pregnancy rupture. So, as we discussed in short about the complication through this flow chart, rupture with internal bleeding lead to the hypovolemic shock, and this is the life-threatening condition or the death. So you might get bored. So is there any confusion or problem? Then you may ask. Is everything
Ma'am,
clear about? Yes.
ma'am, in the signs and symptoms, you told no, ma'am, there will be a pain in case of ectopic pregnancy at the neck as well. How do we connect it with what would be the reason for pain in the neck and all? Okay, if it is pain in the abdomen and the back, that is okay. But if it is on the referring pain to the neck, and then what would be the reason? How?
Hormonal pregnancy that may be referred. Ectopic pregnancy is not always in the pelvic area, like the tubes or cervix or peritoneal cavity. In less than 1% of